All right, can you guys hear me okay? Yeah. So I'm Jessica McDermott. I work at Rocky Mountain Regional VA Medical Center, and I also work at the University of Colorado Cancer Center. I take care of head and neck cancer patients there, and I see everything at the VA. I also am the Deputy Director of Clinical Trial Access at the University of Colorado, so I figured that could be an interesting thing to talk about. All of these treatments and medications and things that we're talking about here, they all come from people taking part in clinical research, and so how can we do that? How can we improve access to patients for that? So, there we go. So first, I'm just going to talk about why is research important. I think that's pretty clear. Then some barriers, and then some solutions. So why are clinical trials important? So basically, what we're trying to do with clinical trials, obviously, is we have a cancer population with a specific diagnosis. We want to come up with good, better treatments for that. And so that takes different parts. First, you have to do things in the lab to figure out, to find new drugs, find new targets, et cetera. Then you test that in animals, and then you bring that into early testing with people. Then that goes on to later testing in people, comparing to what we're currently using, finding better things. And then that has to be approved by the FDA, and then accepted by insurances, and then accepted by providers to actually get to the patients. Some of this may be really basic overview for you guys, but I thought it'd be helpful just to mention some of the different things about research. So when we talk about basic research, that usually means the kind of lab stuff. So looking at cells, molecules, animal studies, et cetera. We find something exciting there, then we bring it into translational research. And that's kind of early things. So, hey, this looked really exciting in the lab or with animal models. Let's start trying it in people. And sometimes, too, we can see things that happen in trials in people and bring that back to the lab to do more basic research. Clinical research is as we're moving a little bit further and studying new drugs, devices, et cetera, in people. And then population-based research is a little bit more when we're kind of looking like retrospectively, looking back at how people did or how groups of people did with certain things, and then using that to come up with new ideas too. For clinical research, we think of that being done in phases. And so briefly, phase one is really that first step. So you found something new or a drug that hasn't been used in this particular disease or in this particular population. And then you start looking at that in people. And those trials were really looking at safety, so what side effects are we seeing, and what the dosing is. So we'll start often with a presumed safe dose, and we'll increase that until we get to what we call like the maximum tolerated dose. Once we find that, we figure out that it's reasonably safe and seems to be effective, then that moves into a phase 2 study. That's when we start targeting often a little bit more in who we're giving it to, people who have specific molecular findings, people with certain kinds of cancer, and that's focusing more on efficacy. Usually these are not randomized in phase 2, and it's not placebo-controlled. It's everybody is getting that drug, and we're looking how effective it might be. Phase 3, so we've gone through phase 2. We continue to find it being safe and seems like it's effective. Now we should compare it to what we currently are doing. So phase 3 is when we tend to see more randomized, where you might have an approved drug, now you're studying that versus your new drug, or maybe there's not a standard of care treatment to compare it to, and so maybe you will have people randomized to placebo. Phase 4 studies we don't do nearly as much, though they are really important. This is when something has been approved or has gone through the phase 3 and seems effective, but we only study those sometimes for a few years. Well, what's the more long-term outcomes for side effects and just how well these drugs work? So why is this important? Obviously, we get new medications, medical breakthroughs, cures, people live longer. We can help with cancer detection. We can better understand how cancer behaves. And ultimately, all of this is to improve quality and hopefully quantity of life too. So why is it important that we get access for everybody to research? When we think of what does everybody mean, there's different kinds of diversity. So different ages, different race, ethnicity, different gender or gender identification, sexual orientation. There's social determinants of health. So where do people live in rural or urban areas? Socioeconomic status, education, genetics, and then other things which we don't look at a ton but are still important: diet, comorbid conditions, environment, substance abuse, et cetera. So it's important of combining or looking at different groups of these people because it helps us understand better the differences in the biologic and medical relevance of these new therapies. So maybe it works for this group of people, but it doesn't work so well in this group of people, and we don't know if we don't include them all in the study. Also, just diverse side effects, quality of life, feasibility of treatment. It gives everybody access to new treatments, these advanced treatments, improve scientific credibility. So if you're trying to tell somebody that they should be on a treatment, but nobody that was like them was included in a trial, it's a little hard for them to accept that. So same with increasing public confidence and trust. Avoiding narrow use or uptake of a product. Again, if you're only studying it in a small portion of patients, then you may not get approval to treat everybody on your new drug. Then also just decreasing liability for post-approval safety events or product withdrawals. So how are we doing enrolling different people in studies? Not so great for a lot of different categories. So for race, ethnicity, these are kind of two different studies that happened. The one on the left is looking at FDA pivotal trials. So if you look at who was enrolled in these studies is the orange one, and then what is the actual cancer population, you can see for Black and Hispanic patients, that divide is pretty great. The other study that's on there is when we looked at phase 1 clinical trials, which compared to population who was actually enrolled, and we kind of over-enrolled white patients. When we look at age, we also skew to enrolling really young patients. So that kind of circle graph there is looking at the blue is who we enroll. So 69% are patients who are less than 65 years. And on the right, it looks at out of the different race ethnicities, what are the ages that people present at? And so that's more like 60% of our patients are over 65. So we actually enroll kind of the opposite of what we should be doing, of who's presenting with these cancers. Location is important. So the darker states enroll more patients in clinical trials. Of course, some of that has to do with population of those states. But generally, if you live, except for in Colorado, but in this area, you probably are going to have limited access to clinical research. Same for rural urban. There's about 19% of our population and 84% of our landmass would be considered rural, but only about 11% of rural patients get enrolled in clinical trials. And when you're looking at phase 1 clinical trials, only 14% versus 86% were rural versus urban living. For sexual orientation and gender identification, we don't actually collect this information really at all. So we don't have questionnaires, we don't collect this, and that's really a missed opportunity to understand how different populations respond with quality of life and other side effects with our things that we're studying. So how do we, what's going on? Why aren't we doing a good job enrolling everybody? Everyone likes to think oh, well, patients maybe aren't interested. Different groups think, that they're just being tested and don't want to enroll in that. But actually, when you look at the kind of, when you're going from patient coming in to a patient enrolling in a trial, there's a lot of steps that you have to take, and actually most of it is not the patient saying no. So if you look at structural, can the patient even get into your clinic? Is there even a trial at the clinic they're going to? When they come there, are they eligible? Do they have comorbid conditions? Does the physician actually talk to them about trials or even think about a trial for that particular patient? And then all the way down to just whether a patient agrees to participate or not. So there's been some studies, this is from the American Cancer Society, of why don't patients participate? And so 77% of the reason was there wasn't a trial available where they were. About 10% patients weren't even asked, and it was only 7% because the patient actually said no. When patients are offered to participate, about 55%, so a little bit over half, will agree to participate in a clinical trial, and that's kind of across the different race ethnicities. In fact, white patients might be the least likely to say yes. But yet, we only have about 7% of our patients participate in clinical trials when you have cancer. So these structural barriers that we're talking about, clinical trials are hard to run. They take a lot of admin work, a lot of staffing, they're very expensive. Your workflow in your clinic takes extra time. It's difficult to access locally available trials, so you have to think about transportation, travel costs, missed work and childcare for patients. Location is really important. So on the left with the country pictures, the blue is patients who live in urban areas. So they have, most patients who live in urban area are 25 miles or less from a clinical trial site. If you're in a rural area, the vast majority are 50 to 100 or even more miles away from a clinical trial. It also depends on where you go. Do they have trials there? So if you go to an NCI-designated cancer center, they probably have more trials, so about 20% of patients might participate. But in the community or even an academic comprehensive center that's not an NCI one, there's just less ability to have trials there because of all of the work that it takes to have them, so less participation in research. Trial eligibility is also a big deal. So when you're designing a trial, you of course want to be broad enough that you can enroll patients and get as many as possible, but you also want to have a pretty, you don't want other things affecting your trial. So you don't want people to be really sick or have lots of other diseases that could impact how well that treatment's working. So the average number of eligibility criteria are 16, and if you're looking at something like a phase 1 trial, it is way more than that, like 30, 40. And we know that if a patient has one or more comorbid conditions, they're much less likely to enroll in a trial, which is kind of shown by those orange things. So decreased odds of enrolling in a trial are much higher if you have one or more other things besides cancer. There's also barriers from the providers. So location, again, not a lot of us work in rural areas, so if we're seeing patients there, there's not a bunch of oncologists to see, and it's harder to have clinical trials open in those sites. Providers might prefer a specific treatment. They might have something in mind that they already want to use. The time that it takes for a provider can be challenging. They might fear that it might interact with their relationship with patients. They might have some implicit bias of who they think might or might not be eligible or want to enroll in a trial. Or they might not even be aware of what trials are available. And patients, so their primary concern is finding the best thing for their disease, and they might not want to wait to screen for a trial or to hear about a trial or to go somewhere else. They also might be afraid of being experimented on. Cost, so medical and non-medical. There's been studies showing that if you have a household income of less than $50,000 a year, you're 30% less likely to participate in a trial. Logistics, trials can be really busy. It's a lot of work to miss, it's a lot of traveling to do. And they also might want control over treatment, especially when you're talking about things that are randomized. Sometimes that's hard to deal with. So what are some solutions that we can do? I would say, being someone who's trying to implement this can be really challenging, but I think, if we work from top to bottom, there's definitely changes that can be made that can make this easier for us and for our patients to be involved in trials. So some solutions, if we're designing a clinical trial, we should be looking at what demographics that kind of cancer is made up of. Are most of our patients elderly? Or most of our patients live in rural areas for some reason? We need to design the trial to fit those patients and to make sure we're enrolling those types of patients. We should try to make our inclusion-exclusion criteria as broad as possible. Sometimes we just kind of cookie cut from one trial to the next and don't really think about why we're including or excluding specific things, and I think that we could be much more thoughtful about that, and I know that a lot of the pharma companies and the NCI groups are really trying to be more thoughtful of that now. But things such as hypertension parameters might exclude a large population, or HIV, if it's not going to really be impacted by a treatment, then maybe those don't need to be fully excluded. We also can look at just the feasibility of this. So sometimes the windows of our treatment for our trials are really tight, like the patient has to get their infusion within a day or two. Or the calendar is really busy, requiring lots of visits to come in, and how necessary are all of those things? When something comes out into the real world, are we going to really be like, well, you didn't get your infusion today or tomorrow, so now we're not treating you anymore? No, we'd be like, let's do it next week or the week after. And then also thinking about financials. So financials for how much it costs the cancer centers and how much it costs the patient too are really important. Decentralization, which I'll talk a little bit more about, but that is looking at ways that we can not just have all of the things that are required for a trial right in that one cancer center, but can we do some things closer to the patient? And then also looking at financials with compensation, housing, transportation for the participants. So this is about decentralization a little bit and things that we learned from COVID, which I feel like we were implementing more and maybe have had to back off on a little bit. But things like consenting, the patient, do they really have to be right there with you, or can they be at home? Can you do some of the checkups by video or telehealth? Can you deliver oral medications to them instead of them having to come pick them up? Can they do some labs and imaging closer to them at home? Is it really that different to get a CBC drawn where they are than where you are? Engaging some of the community centers, so working more, academics, folks partnering more with the smaller centers can be really helpful. They have, again, done studies looking at, well, would patients be more likely to participate if they could do some of these things further or closer to themselves? This is really hard to see, but things like trial activities at a local facility, wearing wearable technology to capture data, having health apps to track things, having check-ins for telehealth, all of those things would significantly increase people's ability to participate in trials and willingness. The other thing is financial support. It can be really expensive for patients to go through cancer treatment generally, and then clinical trials can be even more expensive because it's more visits. The National Academy of Science, Engineering, and Medicine put out a statement that all sponsors should provide adequate compensation for research participants. I think that that is a great idea, but there's certainly barriers. I mean, these trials are already really expensive. I think the budget could get enormous if you're doing that. There's some ethical concerns. Are you coercing people to be involved in trials if you're providing them money? And some legal issues. But there are some policy efforts that are going on to try to just improve the financial aspect of participation in these things. Patient knowledge is also huge. Only about 41% of people in the US really understand what a clinical trial is. And I would say even that understanding is pretty basic. And most patients have really never even had a discussion with a provider. So this is looking at patients asking, have you ever been invited to participate in a clinical trial? And 87% said no. And out of those who were asked, at least half of them, would participate. The way to give knowledge, though, is to keep it simple and timely and focus on their patient needs. So there's been a lot of just trying to educate generally broadly, what is a clinical trial, what is cancer research? And that seems to be a little less helpful than hey, you have this diagnosis, we potentially could look at research for you at this time, and what does that mean and what might be available, as opposed to just a big, broad picture of what research might be. Provider engagement is also extremely important. When you ask people with cancer where they would want to most get their information, they still really want to get it from their healthcare providers. They, of course, use the internet, but when we're telling them things, it can mean a little bit more. And so, as providers, we need to know about trials and how to get that to them. So partnering with academic centers, trial centers, and us partnering with each other is huge. Having some reimbursement for time would probably be helpful for some providers to have the ability to talk about research and trials with their patients. Easy access to trial info. Sometimes it's really hard, even for me, when I'm trying to look somewhere else for where a trial might be for a patient, to really find good data on that. Making sure the referral process is easy. And then, of course, keeping up with all your organizations and your education. Workforce and diversity is important. People like to hear about things from people like them, whether it's age or gender or race, ethnicity, et cetera. So having a more diverse workforce is, of course, important. So I won't go much more into that. And then participant access, so easy referrals, easy enrollments, having patient navigation, which I'll get into a bit much, trial decentralization, study documents in their language, all of these things can help participation. I think important to all of you is oncology trial navigation can be huge. So patients can get education from nurse navigators, and I think that can be immensely helpful. The nurse navigators can also collect information from the patient and their providers to help the trialists to see some pre-screening things. Might we have a trial for this patient without wasting their time? The American Cancer Society actually has its Leadership in Oncology Navigation certification, which I've heard is pretty good. And then there's also online clinical trial finding matching sites through AI, which are okay. And then finally, I think this is my last slide, just other ways of broadening engagement. There's patient advocates out there who can help other patients look for trials and understand research and what that process means, and they're really helpful. Going to local events, whether it's health fairs, et cetera, for researchers and for patients can be great. And then sharing of study results has been shown to be an important thing. Sometimes people are in studies and they never hear, especially if it's a negative study, what happened with the outcome. And then they have harder time trusting, well, you guys didn't even tell me what happened with this trial. So being better about that from us, researchers, was good. And then, social media is used for a lot of things, so. Okay, I think I got through all of that. So what questions can I answer for you guys about this?
Hi, you mentioned the role of placebos in clinical trials. Does that mean that people are receiving a medication that they think is, like a drug, but it ends up being nothing? Is that what's happening?
So it can be, but it's pretty rare in cancer. So most of our cancer clinical trials are going to be comparing a standard of care medication like a chemotherapy versus the new study drug. It would only be in cases where the standard of care would be nothing that we would use a placebo. And so that could be in some cancers, for example, we will do surgery and then radiation, and then they'll just be on observation. But we might have a new drug that we might think that if you take this after the radiation, for example, that it could decrease the chance of your cancer coming back. And so that could be a placebo-controlled trial where you get the standard of care, which would be nothing, versus this new kind of maintenance treatment. Or some things like, let's say CLL, you might have as like part of your standard of care, you could just be observing patients. They wouldn't be on treatment because we don't expect their disease to progress or have any problems for a while. But maybe we're studying something new that we think could modify how patients do, and so that could be that. So those would be the only circumstances where you would really get like a placebo. And placebo, yes, meaning that they're getting nothing. Sometimes it is what we call blinded, where they don't know that they're getting the treatment or not. And sometimes it's unblinded, where the patient knows that they're not getting, that they're just getting, standard of care, which would be nothing versus the treatment. Most of our cancer treatments, it's pretty clear if you're getting a treatment or not, so it's hard to be fully blinded to that fact.
Thank you.
Any other questions? Okay, thank you.